So welcome back. In this video tutorial, we're going to be looking at how to change the pain and discussing neuromodulation, which seems to be a little bit of a complex treatment. So Diarmuid, could you talk to us about what is neuromodulation? How successful has it been?
Well, neuromodulation means changing the way nerves behave. Modulation just means change. And generally, we talk about neuromodulation. What we're talking about is using a device that delivers electricity or a drug to a nerve or bunch of nerves in order to change the way they function and decrease the patient's pain. So after the gate control theory of pain was formulated in the 1960s by Melzack and Wall, the researchers in the United States decided that perhaps applying electricity to the spinal cord would be useful. The first number of experiments were successful, but blighted by the type of equipment that they were using and complications. Fast forward to the next 20 years, there was significant development in understanding, in technique, in application, and of course the engineering that was associated. So nowadays we have a situation where we can place up to 16 or up to 32 electrodes in the spinal cord or near a nerve in order to change the way that nerve behaves. And so this is done usually via the epidural route, and it is preceded by having a trial. It is one of the only operations that I know that you can take for a test drive first. And essentially it is placing a wire about the size of this. This one has 4 electrodes on it, but there can be up to 16 electrodes. They can be put into the spinal cord in the back of the epidural space, in the cervical spine, thoracic spine, lumbar spine, sacral spine. And more recently, we can put them at the nerve roots, the so-called dorsal root ganglia. There are different types for different patients, different pain states, in different parts of their pain journey. It is not applicable to everyone. In fact, the number of patients is vanishingly small. So it will be a percentage of less than 10% of patients who will respond to this type of therapy. It is expensive and it needs to be assessed extremely carefully. The trial, the implant, and the management of these patients needs to be undertaken from assessment through to ongoing care by somebody who has specific knowledge, experience, training, qualification, and ongoing expertise in the management of these. The assessment cannot and should not be done by somebody who is not familiar with this type of technology. If the trial is successful, an implantation of a generator, in other words, a battery which is smart with a way of producing different techniques and different settings to the spinal cord, it would be in the order of the size, I always say, of a mint slice or a Tim Tam biscuit. But that is where the brains of this lies, the engineering and the computer modeling. This is a rapidly evolving and changing field. There are so many different techniques, so many different programming parameters, some of which can be used together, some of which can be used sequentially, and they need to be individualized for the patient. Obviously, the informed consent is important, indicating the benefits, the risks, and the alternatives, including not doing this particular technique. There are risks, they are small, but they are not zero. And the costs can be considered, not just the capital costs, but the costs ongoing. So that is a very short synopsis of what neuromodulation is. The other side of it is the ability to deliver high concentrations in small amounts of opioid-like drugs into the central nervous system. This is a technique that was actually pioneered in the 1970s here in Australia and South Australia, for a fact. For cancer pain, it is used for a very, very, very small number of patients with persistent pain. and we use what's called an intrathecal drug delivery system. Again, it's associated with some problems, with some danger. It's not suitable for anyone. Everyone. It can be suitable for only a very small proportion or percentage of patients. Again, it needs to be managed by somebody who has intimate knowledge of this technique and managing the patients in an ongoing fashion. Who should decide? It should, in my view, it should be a neurosurgeon, a neurologist, a specialist pain medicine physician, or those who have ongoing current expertise and qualifications in doing this. The Faculty of Pain Medicine is currently forming a program to train specialists in the management of interventions, including neuromodulation, and therefore the Faculty of Pain Medicine is probably best placed to make these decisions. It is a multidisciplinary faculty with specialists drawn to the specialty of pain medicine from psychiatry, neurosurgery, neurology, anesthesia, rehabilitation medicine, and psychiatry. So multidisciplinary in all forms. Neuromodulation for a very small proportion of patients and very carefully selected.
Yes, it sounds like a very intricate procedure and obviously needs to have specific expertise in terms of who should undertake this kind of procedure. There also seems to be a lot of letters associated with neuromodulation, such as SCS, DRG, and so on. Could you provide a little bit of insight into what these refer to?
So SCS is spinal cord stimulation, and that can be applied to the spinal cord, usually in the epidural space at almost any level of the spinal cord, depending on where the pain is. DRG stands for dorsal root ganglion, that is the cell bodies at the root of the nerve just as it exits from the spinal column. This is where the axons and the cell bodies connect, and it is a way of changing probably how gene expression occurs at that level. PNS is peripheral nerve stimulation, and that's applying electrical current to peripheral nerves, those ones outside the central nervous system, the spine and brain. There's PENS, which is percutaneous electrical nerve stimulation, which is a temporary technique for inducing a phase 2 block in some nerves. And that is an electrical, physioelectrical way of stunning the nerve, which is probably not a very accurate description of it, but it's one I use for the patient. So stunning the nerve can be used for peripheral nerves, headache, scar pain, or very localized pain. And then the pumps which are involved is made by one manufacturer. It's a pump that's situated usually in the abdomen or in the lower part of the back, and gives a continuous infusion of opioids or a mixture of opioids and local anesthetic, clonidine, Baclofen, and various other drugs. Again, very, very, very specialized technique and very specialized equipment required.
And are there any specific presentations that are more suited to neuromodulation?
Well, yes, there are, is the answer. The International Association for the Study of Pain and the International Neuromodulation Society have guidelines in the patients that we select for this type of therapy. Those who have radicular pain or pain from the radicals or the nerve roots, pain in one leg or pain in both legs, are generally more responsive to this technique. But in recent years, the techniques that we can apply for axial back pain, neck pain, shoulder and upper limb pain, and even headache have improved. Patients with such diseases as chronic pancreatitis and even angina, which is not responsive to other therapies, have responded very well to spinal cord stimulation. And because it is electricity and not drugs, there are no side effects in the way that we know that they exist with medications. That does not mean that it is free of danger. It needs to be applied and selected and managed in a specialized way. So there are a growing list of indications, but I'd like to think that the core axial back pain, unilateral, bilateral lower leg pain, upper limb, shoulder and neck pain would be the cornerstones of this therapy's application.
Any application for migraine?
It has been applied to migraine. It has been applied to occipital neuralgia, which may be a subtype of migraine. And it has been applied to occipital frontal headache. And these are where the electrodes are placed above the eyebrow and at the back of the head. So that's a subset of neuromodulation, probably in the realm of neurosurgery rather than pain medicine. Similarly, neuromodulation has been used in the brain for such things as functional problems like Parkinson's disease and spasm following stroke and those sorts of disorders. Again, outside the realm of specific pain, but the applications are broadening as the engineering gets better.
Fascinating. Well, thank you so much for giving us such in-depth understanding of neuromodulation. I know it's a term that many of us have heard about, but certainly have never understood to the degree that you've now shared with us. So thank you so much, Dr. McCoy. We're going to move on now, looking at how to manage the pain and looking specifically at pain management programs. So I do hope you'll join us for our next video tutorial.